Welcome back to Quick Hits, the podcast from Health Data Movers, where we sit down with healthcare and health IT leaders for quick, candid conversations about what's shaping the industry today. I'm Ken Booth, and today I'm joined by Mohammed Abdelaziz. In this episode, we talk about the realities of healthcare data, what it takes to move from strategy to execution, where organizations often get stuck, and how leaders can turn complexity into real momentum. Mohammed shares a thoughtful, practical perspective on what it truly means to make data work for patients, providers, and health systems. If you're navigating growth, modernization, or large scale change, this conversation is for you. Let's get started. Welcome to another episode of Quick Hits. I'm your host, Ken Booth, joined this week by a couple of special guests, Brooke Foster. It's her first time co-hosting on Quick Hits, so welcome, Brooke.
Thanks, Ken. Excited to be here.
And then we also have our guest this week that we're really excited to talk to is Dr. Mohammed Abdelaziz. He's the Hospital Medicine Medical Director at Mercy Health with the Kings Mills Hospital in Cincinnati, Ohio. Dr. Abdelaziz, welcome to the show.
Oh, thank you for having me on your podcast.
No, we're really excited to have you on, and we love getting an opportunity to talk to medical directors and CIOs, as you know. So we really are excited to kind of hear about your journey, really. So let's just get right into it. You've served as both a hospital medicine medical director and a physician informaticist. Questioning how do those dual roles shape your perspective when it comes to leading clinical and digital transformation initiatives?
Great question. The way I think about it is just as being bilingual, just being able to speak the clinical language, but also savvy enough to speak the technical and operational language. You need that person with both expertise in both areas, that person who can bridge the gap between the technical teams and the clinical teams, kind of translating their needs to the clinical needs to the technical team.
Mm-hmm.
I also think about being an informaticist is not only about the technical skills, but being an informaticist, you learn a lot of what I would call soft skills. Things like change management, conflict resolution, and negotiation. And these skills are usually universal. You can apply them everywhere, including within the hospital setting and even outside the hospital.
Excellent. So, how would you say that that's affected that development of those soft skills? How would you say that has benefited you?
Yeah, many times when we're dealing with rolling out a new piece of technology or new workflow,
Mm-hmm.
the technical build or implementing the technology or deploying the technology is usually not the most challenging hard part of the process. It's actually adoption
Mm-hmm.
and having that integrated into the workflow. I can go and spend thousands or even millions of dollars, buy the best out there piece of technology, get it deployed across my organization. But if nobody is using it, or if they are using it the wrong way, or they are using it inefficiently, I'm not getting that return of investment. So you need to be able to lead change, understand change management, and be able to understand the why and explain it to your clinicians.
Mm-hmm. No, that makes perfect sense. So, you've been a hospitalist for over a decade. What major shifts have you seen in hospital medicine, and how have those needs changed or influenced the needs of clinicians at the bedside?
I would say there's definitely more shift towards a more patient-centered care
Mm-hmm.
over the last 10 years or so. There is also most systems now they are putting a greater focus on quality, safety, and patient experience.
Sure.
Hospitalists have increasingly become the owners of many of these domains, which kind of expanded their role from just treating medical issues. But this came with a lot of other responsibilities. So now hospitalists are facing more documentation requirements, more messages and queries to deal with. And with these changes, hospitalists also need better tools and smarter workflows to help them focus on patient care and spend less time tackling these administrative tasks. And these changes also led to more needs for smarter tools. And maybe with all the advancements in technology, we'll see more smarter tools and incorporated into the workflow. This way, they are focusing more on their primary goal, which is taking care of patient.
Yeah, I see. Yeah, that makes a lot of sense.
Looking at the tools that you're using, as someone board certified in clinical informatics, what principles guide your approach to optimizing Epic and building decision support tools that truly help, not hinder, the clinicians?
Yeah, I think the my guiding principle that I stress about is always start with defining the problem. You can't ignore this. You cannot just jump into solutions without spending considerable time understanding the problem. There is a say by one of the greatest American inventors, Charles Kettering. He said, "A problem well stated is a problem half solved."
Hmm.
So we often jump into solutions without spending enough time defining the root causes of problems and underlying issues we're trying to fix. And I think we need to slow down sometimes and not get excited by shiny tools or shiny solutions that we may just implement out of pressure without actually understanding the root causes of many of the problems, which sometimes we're just treating with symptoms of much, much deeper problems.
That's a great perspective, and I really appreciate that quote because, yeah, how many times have you been told, "Hey, this is a new tool," and you dive in, you
Mhm.
start using it, only to find that the problem hadn't truly been understood yet, and so now you've created technical debt. You're kind of in the weeds, and here's this new tool that maybe there's pressure to continue using, and so yeah, better tools and smarter workflows doesn't necessarily mean more. It just means understanding the problem better. So yeah, thank you. I really appreciate that quote. We'll probably use that in the future, I'm sure. Um,
Mhm.
can you do us a favor? Can you share like an example of an inpatient workflow improvement that had a meaningful impact on patient outcomes and operational efficiency? Like, how did you arrive at that particular improvement and what made it successful?
Yeah, I mean, I can just talk about a recent project that we implemented at King's Mills. So we recently implemented a change in our hospitalist workflow by adopting collaborative bedside rounding. So many of us physicians were so used to work in silos, and I think this translates into less aligned care plans and delays and inefficiencies. So at King's Mills, we decided to shift to a collaborative bedside rounding model that incorporates the nurse. So every time the physician or the hospitalist goes to see the patient, they go with the nurse. Since we made that workflow change, our initial assessment that we have seen improved communication, definitely less gaps and more aligned teams, and definitely more efficiencies. Personally, as a practicing physician, since I have adopted this model, I feel like I'm getting less messages, less pages,
Mm.
and even I feel the patient is more engaged with the provider this way, that as we communicate with the patient as a team rather than communicating with the patient as siloed providers.
That's huge because yeah, patient engagement is so important because you need patients to advocate for themselves as well, right? So yeah, if they feel that relationship and it's easier for them to have meaningful dialogue, then everybody benefits. That's great.
Dr. Abdelaziz, You work within a large integrated health system at Bon Secours Mercy Health. How do you balance system wide governance and standardization with the on the ground needs of local hospital teams?
Yeah, I mean, definitely in such setting, you need to be, I would say, more mindful when solving a local problem that your solution has somehow to fit within the broader governance and shared workflows. And to achieve such balance, you should be able to clearly articulate the local needs and show how they align with system goals. It becomes more about finding solutions that make sense both locally and system wide. You cannot just address the local problem without putting emphasis and also knowing about implications for the rest of the system. So it's a little bit of a challenge, because now instead of needing to maybe discuss the problem with one or two stakeholders, you find yourself needing to go through different committees and different groups. But I think once you get to that solution, it's not only gonna help your local site, but it can also scale into other sites.
Mhm.
Have you had to do much to streamline that process now that you have a larger number of teams that want to weigh in?
Yeah, definitely. Knowing the right people.
Hmm.
You start. Once you start knowing your system, knowing the right people, knowing the owners of the different parts of the process, that knowledge and developing those relationships, it does help facilitate finding the right solutions for your problems.
So, what role does data, real time reporting, or whether it's retrospective reporting, what role does that play in how you lead or the quality of the initiatives that you're implementing across inpatient settings?
Yeah, I mean, I'm a big believer that every conversation about quality and safety has to start with data.
Hmm.
We absolutely need to quantify the problem so we can understand the impact of the problem itself, but also the impact of the proposed solution. You know, Otherwise, we're just making guesses and hoping for the best. Uh, Even more importantly, and you kind of mentioned real time data, is you need real time actionable data, which would allow us to intervene sooner and
Hmm.
also support our clinicians in a meaningful way. We cannot just request a report and wait for 4 weeks to get the report. By the time we get the report, we have moved to a different level of the problem, and then implementing a solution based on data from 1 month ago.
Right.
And then when we do the intervention, then we pull another report. It takes another 2 or 3 weeks to get that report. Then you just kind of waiting for more weeks to fix any issues with your intervention. I think this way of doing business within healthcare has to change, and I see a lot of promising solutions out there that people at the bedside, people closer to the process, able to get that information real time, and they can implement solutions sooner than later.
Yeah. So, can I assume that you're talking about just the kind of the integration of AI and predictive analytics?
Yeah, I mean that's part of it. But for example, like with Epic now, you have the slicer dicer tool, and
Mm.
that slicer dicer tool is a great tool for even people who are not very savvy with the analytics, building dashboards, and also some of the reports that can be built within Epic that also can help extract some of that data
Mm.
more real time and more effectively.
Looking into AI and predictive analytics, are you excited about any new tools coming out with Epic that are advancement from the clinical informatics standpoint?
Yeah, I mean, I'm excited about a lot of things, but I think it's no secret that clinicians spend um, too much time documenting.
Hmm.
So I'm most excited about all things that uh, can maybe reduce this documentation burden.
Hmm.
Things like ambient AI, AI generated hospital course and discharge summaries, and ART, which stands for Augmented Response Technology, which is an AI tool used to draft responses to patient messages. And if you work in the outpatient setting, providers and doctors, they spend too much time just trying to catch up with messages.
Hmm.
With respect to predictive analytics, I don't think the real challenge right now is building the model itself. You can build great models with great accuracy, with high prediction capabilities. I think the real issue right now that we're facing is integrating all these great models into our existing workflows. So essentially getting the right information to the right clinician at the right time within the right workflow so they can make the right decision. That's the real challenge.
Hmm.
And that's something we should still continue to explore and work on improving in the future.
So you run the risk of, again, now the clinicians don't have to spend as much time documenting, but because of ambient AI, now you're worried about them having too much documentation to go through in order to make these decisions, right? Is that kind of what you were saying?
Yeah, I mean, I think with the predictive analytics, okay, you're telling me, well, this patient has 80% the chance of being readmitted to the hospital.
Hmm.
Okay, that's nice to know, but what should I do about it? Okay, now that I know that information, what things that I can do to change that?
Hmm.
I think that's the most challenging aspect. Is you can build all these models, they can predict different things, but if you don't have a plan that comes with that, then that information is just noise.
That makes sense. Well, can I ask you this? Is there any technology that you were initially skeptical about that has kind of surprised you in its ability to kind of ease the burden on clinicians?
Naturally, I feel like usually I would fall into early adopter
Okay.
bucket.
Okay.
So um, I like to try new things. I was surprised probably by the output of ambient AI.
Mm.
And I felt for the most part the note quality itself was decent. The medical decision making part of it was probably lacking. Probably that will get better.
Mm.
But overall, I felt that ambient AI technology has great potentials and very decent output.
Let's take a quick break. At Health Data Movers, we know that data migration isn't just about moving information from point A to point B. It's about making sure your clinical and operational data is accurate, accessible, and secure so your teams can focus on delivering care, not chasing records. Whether you're consolidating systems, switching EHRs, or sunsetting legacy data platforms, our data migration experts help you move confidently through complex transitions. We bring proven tools, repeatable processes, and deep healthcare experience to make your migration seamless. If you're planning a system change or even thinking about one, let's talk. You can learn more at healthdatamovers.com. Now back to the show.
Portion of it isn't as strong. I'm sure it's improving, but what do you think improves that? Just more data, or do you think it's better training on the user's part?
I think with predictive analytics, you're looking at integration with
Hmm.
workflow. These models, you continue to train them, they're gonna just continue to perform better. I don't think necessarily it's about building the model. As long as you feed the right information and you train the model on large data set, and that's becoming more and more widely available and much easier to do, but integration into workflow remains the challenge.
Hmm. Well, that makes sense. So then, we talk about clinical decision support. It easily can become overwhelming for clinicians. So, what are your strategies that are effective for creating like high value alerts, right? Reducing unnecessary noise. I'm sure your clinicians run into notification fatigue where if
Mhm.
everything's everything's a priority, suddenly nothing is. So
Mhm.
what's your process there for just making sure that they're looking at what's actually
Mhm.
important at the moment?
That's a great question, and this is one of the things that's, as you kind of alluded to, is very frustrating and annoying for many physicians for good reason. And I think my biggest strategy is less is more. We should only build high value alerts, and also at the same time be willing to retire low performing ones, because you can't just be adding more and more alerts in response. Most of the time it's response to system issues rather than actually addressing the underlying problems. There should be a process to go back, evaluate, and
Mhm.
reevaluate the performance of whatever you built into the system. And if such alerts or tools that you have implemented deemed to be ineffective, improving the process or solving the problem, you should get rid of the alerts that they're not performing well.
Mhm.
It's also, it's not a big secret that these alerts simply they don't work. I mean, most clinicians often ignore them, and
Mhm.
it's not like, okay, I built an alert, that's the going to be the permanent solution, and everybody will just do the right thing. Alerts are not necessarily the most effective solution. Many times it can be helpful, but overusing them can lead to bad outcomes sometimes.
Sure.
Uh, yeah, so we need to be very careful with adding more and more of them.
Yeah. How do you measure the alert versus the outcome? Is it just analytics just to determine like, why was this decision made, or was there a series of poor outcomes because we implemented a new policy, or how do you then debrief to find out this is valuable or this is not valuable?
Yeah, I mean, again, I think it starts with defining the problem you're trying to solve.
Okay.
Before even building the alert, you need to outline the problem that you're trying to solve and the desired outcome, and then find a way to measure the performance of your alert and compare that to the outcome that you're trying to achieve. If you build the alert with no well defined problem or with no defined desired outcome, you're definitely risking not being able to effectively measure the outcome or the effectiveness of whatever you have built. And you spend considerable time and hours,
Hmm.
analyst time, putting building the alerts and testing them and releasing them into the system and educating your clinicians about the alert. So you should also invest considerable time defining these metrics beforehand.
Great advice.
You've collaborated with multidisciplinary teams from IT to nursing to operations. What have you learned about building alignment and trust across those groups?
Yeah, I mean, I think first of all, we need to acknowledge that every group comes with different perspectives, priorities, and needs. And we can just make assumption that everyone see the problem the same way. A physician versus a nurse versus a technician versus an administrator, they have been through different experiences and they deal with different set of problems every day.
Hmm.
So as long as we acknowledge that, yes, we can have different views to the same problem, I think that's the very first starting point.
Hmm.
Then alignment starts with understanding those viewpoints and finding the shared goals. And I think in healthcare it's very straightforward and very easy because that shared goal is usually the patient,
Hmm.
right? So if we make everything about the patient, that makes it much easier conversation. And talking about trust, trust, something that you earn, And that comes from showing respect for each group, and as well as being very transparent about how you make decisions. So you need to highly emphasize that this is a shared decision making process, so you can get that buy-in from the different groups.
How do you help IT? Right, because I come from a more of an IT background versus the clinical background. How do you
Mhm.
help IT understand the importance of the patient? Because sometimes, we've heard of other health centers and organizations just doing different exercises to really help IT see the end result. Like, what do you guys do?
Yeah, I mean, in a healthcare setting, as a matter of fact, I look at IT as a clinical operation.
Mm,
What you guys do in IT is not about software or about network, but it does actually affect how we deliver care to the patient. If our system is out, we cannot deliver care. I cannot see labs if something is not working. So just understanding that even what you do in IT, it does touch someone's life.
hmm
It does touch how we provide care. You support us, you buy into the mission of the organization, which for most healthcare organizations, taking care of patients. I think that makes it a better conversation, rather than we just like, I'm just here to solve this technical issue. I'm here to help you take care of your patients.
Mhm.
Excellent. No, that's great. Well, we've really enjoyed our conversation. We just have one more question for you. Looking ahead, what are some emerging trends in either hospital medicine or informatics that you see as having the biggest impact on patient care in the next 3 to 5 years?
Well, there are a lot of things evolving in this space, but
Mm,
a couple of things that I'm kind of looking into, and I think they will gain more traction in the future. The first thing is the hospital at home model. The hospital at home model will likely continue to grow.
mhm,
Although it's currently facing reimbursement uncertainty, I predict this is likely will change because we have seen some preliminary evidence that this model is working and is helping a lot of people. And this is probably somehow this conversation will continue to shape how we deliver care. I predict that probably we'll see more hospital level care shifts into the home.
mhm.
Instead of needing to keep patient in the hospital, we'll be able to do a lot of these things at home.
When you say hospital at home, what do you mean? Like, what kind of services can be done in the home versus having them come in?
Yeah, so some healthcare organization, they have already started that around COVID, which is basically the same. A lot of the services that traditionally we have only provided in the hospital, now we can do at home. So they can do things like monitor, remote monitoring. They can
Mm-hmm.
that the physician will go actually see you at home. They will round on you. They can do IV antibiotics at home. It's
Hmm.
not only home. It's not only about home health care, but it's actually providing and seeing these patients every day and monitoring them while they are still at home. They can do like blood transfusion, a lot of the things that traditionally we have not done at homes. Now we're taking that hospital and moving it into your home. That's
Interesting.
essentially that the hospital at home model. Yeah.
That's great.
Yeah, I mean the other area that I just wanted to touch on is consumer informatics. um, Now we see a lot of things like wearables and home devices, and these things they generate a lot of data, and probably in the future we'll find better ways integrating such massive valuable data into the medical record.
Right.
Continuous glucose monitors,
Mhm.
CGMs, these are now becoming very common, and they generate a lot of useful data that they should somehow be integrated into the patient journey and into the medical record. So probably we'll see more of that in the future.
Excellent. No, thank you for explaining that. Again, we've really enjoyed the conversation. Looks like Tyler joined. Tyler, did you have any final questions or anything for Dr. Abdelaziz?
No, Dr. Abdelaziz, thanks again for joining us, and thanks for letting Brooke do her inaugural podcast. Really excited to get other members of the team involved. So I appreciate you being part of this pilot, and I know she did an excellent job.
Well, thank you, Tyler. Thank you, Brooke, and thank you, Ken, for the opportunity to be with you on this podcast. And very excellent questions, and I think great discussion with you both.
Oh, absolutely. Yeah, we'd love to have you on again, and just really thank you again for your insight. And again, I really love that quote that a problem well stated is a problem half solved. So I think that's just I love when we get nuggets of wisdom like that. So thank you again for being on the podcast.
Yeah, thank you for coming on and talking with us this morning.
Thanks again for listening to Quick Hits, a healthcare technology podcast for healthcare technology professionals. Follow us on Spotify or Apple Podcasts, and don't forget to reach out to us with feedback, suggestions, or even people in the healthcare technology industry you think we should interview. Send an email to quickhits@healthdatamovers.com.